Now, in the third section of our lecture, Disorders of the Nasal Cavity, we will talk about the condition known as cerebrospinal fluid rhinorrhea. So, cerebrospinal fluid rhinorrhea, what is cerebrospinal fluid rhinorrhea is when the cerebrospinal fluid CSF, which is the fluid that flows around the brain and spinal cord, as a result of some injuries or trauma, can start flowing from or coming out from the nasal cavity. That's the rhinorrhea. Aurea is the flow and rhino is the nose. So flow of cerebrospinal fluid from the nostrils or the nasal cavity. So in this we will talk about how we can diagnose this condition, and after the diagnosis how it can be managed and treated, and what are the principles of repair for the cerebrospinal fluid rhinorrhea. So cerebrospinal fluid rhinorrhea is the leakage of CSF in nose. It may be clear fluid or mixed with blood, as in acute head injuries. So if there is injuries, or especially after head injuries, it can be blood-stained fluid or blood-stained cerebrospinal fluid coming out of the nose. So it can be clear or it can be blood-stained depending on the cause of the rhinorrhea. Here if you see in this diagram, this is the brain. Then we have the dura mater. Dura mater is the we have three coverings of the meninges, three layers of the meninges, which is the membrane that covers the brain and spinal cord. And these membranes we have pia mater, arachnoid matter, and dura mater, pad. So this is the dura mater surrounding the brain, and this is the cerebrospinal fluid that flows around the brain. The physiology is CSF. Physiology is the normal study of the cerebrospinal fluid, how much is produced, how it flows. So CSF or cerebrospinal fluid, it acts as a buffer against sudden jerk. Brain and spinal cord, all the important structures in the body, the brain, spinal cord, heart, lungs, abdominal organs, they are created and they are cushioned by the fluid to protect them from the sudden jerks or sudden injuries. So they should be protected by that fluid that flows around them. So in the brain, the cerebrospinal fluid acts as a buffer against sudden jerks. The cerebrospinal fluid is produced or secreted by the choroid plexus, and this fluid which is produced by the choroid plexus is absorbed in dural venous sinuses by arachnoid villi. So villi are the finger-like projections. Once it is produced by the choroid plexus, it is absorbed by the arachnoid villi. Also, the total volume of cerebrospinal fluid is about 90 to 150 ml. So normally that's the amount of CSF that flows around the brain and spinal cord, which is 90 to 150 ml. And then the rate of secretion, at what rate it is secreted at a rate of 20 ml per hour, and there is about 350 to 500 ml of cerebrospinal fluid is produced per day. It is replaced 3 to 5 times a day. Because it is producing very rapidly, it is replacing constantly, and it is replaced 3 to 5 times daily. Normal pressure of cerebrospinal fluid is 50 to 150 millimeter of water, H2O, water. So 150 to 150 millimeter of water. Pressure rises on coughing, sneezing, etc. So whenever person coughs, sneezes, as a result of this, the intracranial pressure increases or the cerebrospinal fluid pressure increases. The causes of CSF rhinorrhea, we have trauma. Trauma is very, very important cause in the hospitals, in the emergency ward, surgical ward especially. After the patient comes with head injuries, usually they have rhinorrhea or there is leakage of CSF from the nasal cavity because of the fractures of the skull bone. So trauma is one of the very important cause of CSF rhinorrhea. Accidental or surgical trauma. Inflammations, different inflammations can also cause CSF rhinorrhea, which include mucoceles of sinuses, sinonasal polyposis, and fungal infections. Neoplasm, which can be benign or malignant, can cause CSF rhinorrhea. Some congenital lesions like meningocele and gliomas can cause rhinorrhea. And some idiopathic unknown causes can be spontaneous leak sometime occur. No cause is found. So all these are the different conditions can cause CSF rhinorrhea. But as I mentioned, accidental injuries, head injuries, are very, very common cause of CSF rhinorrhea, but other causes can also be not excluded, like inflammations, neoplasm, and congenital lesions can also lead to CSF rhinorrhea. The sites of leakage, how it can leak into the nasal cavity. The sites are usually the frontal sinus. These are all the sinuses, injuries or trauma. Frontal sinus, ethmoid sinus, sphenoid sinus, and then all these can cause these sites of leakage. So CSF from anterior cranial fossa reaches nose via cribriform plate, roof of ethmoid air cell. This is the ethmoid sinus, the roof of ethmoid air cells, frontal sinus. Then CSF from middle cranial fossa follow injury to sphenoid sinus. So sphenoid sinus can lead to injury to middle cranial fossa. So frontal, anterior cranial fossa, middle cranial fossa, and then we have posterior cranial fossa. The anterior cranial fossa and middle cranial fossa, whenever they are involved with the injuries, usually the leakage of cerebrospinal fluid can occur into the nasal cavity through the ethmoid sinus, frontal sinus, and sphenoid sinus. If you can see, these are all these sinuses. Any injury or trauma can cause the leakage into the nasal cavity here. The diagnosis is usually it's important. We should differentiate between the CSF fluid or just the normal regular nasal secretions. It's important to differentiate, so we should know that it's the CSF rhinorrhea or just the allergic rhinitis or secretions from any other cause. So what are some differential features between the two secretions? First, history is important. History, nasal or sinus surgery, head injury or intracranial tumor. Any injury, any surgery performed, if the leakage is after that, usually the first thing that should come to the mind is that it might be due to it's the CSF fluid, not the normal nasal secretions. If there is sneezing, nasal stuffiness, itching in the nose or lacrimation, then usually it's the nasal secretions. Flow of discharge, another important differentiating point. Flow of discharge, a few drops or a stream of fluid gushes down when bending forward or straining cannot be sniffed back. But in other case, continuous, no effect of bending or straining can be sniffed back. It's an important differentiating point because one can be increased when bending forward. The other has no effect when the bending is done or the straining is performed. Then what's the character of the discharge? Thin, watery, and clear. CSF is just like a fluid, normal fluid. It's clear, it's thin and watery. But in another case, it's slimy, mucus, or clear. So that's like a mucus. It's not as watery as the CSF. Taste. CSF is sweet taste and the nasal secretions are salty. Sugar content. More than then now these are not just the simple tests, they are the lab findings of the two secretions here. Sugar content more than 30 milligram per deciliter compared with sugar in CSF after lumbar puncture, as sugar is less in CSF in meningitis. So it's about more than 30 milligram per deciliter, and in another case is less than 10 milligram. So it's a big huge difference between the two in the sugar content. Then presence of beta-2 transferrin in CSF fluid is always present, and then in another case is always absent. So these are some very important distinguishing points to differentiate between the cerebrospinal fluid leakage or the nasal secretions, especially even after the head injuries. If it's neglected or attention is not paid, then if there are secretions from the nose, that's the indication we should know whether it's CSF or the nasal leak, because we need to follow up for this very, very closely. Reservoir sign, double target sign, nasal endoscopy, and microscopic examinations. These are all the other diagnostic tests for the rhinorrhoea. And then we have double target sign, double target when it is stained with the blood. We have double color of the secretion, so that's the double target sign. Lab test, we do the glucose testing by oxidase, per oxidase, or biochemical estimation. Usually they are not any longer used, not recommended. Checking for specific proteins is important. Beta-2 transferrin, as I mentioned in the previous slide, beta-2 transferrin is very important, always present in cerebrospinal fluid, never present in the secretions. And then also beta trace proteins can be looked in the lab tests. Localization of the site of damage, different tests that can be used: high resolution CT scan, coronal and axial cuts if there are bony defects. and axial cuts if there are defects of frontal or sphenoid sinus. And usually the cuts are taken at 1 to 2 millimeters. So 1 to 2 millimeter size cuts, coronal and axial both if the bony defects are present, and only axial if we have defects in the sinuses. MRI is a T2 weighted image, and it's a non-invasive test that can be also used for localizing the site of the leakage. In case of encephalocele intracranial pathology, the MRI is done. Intrathecal fluorescein study, which diagnose the site, or it can be used intraoperatively during the operation or surgery. It's an invasive method and use has been abandoned because it's of invasiveness. Then CT cysternogram. CT cysternogram is intrathecal injection of iohexol, which is a dye, CT scan, and then it's not favored. Again, the most important test that should be done to localize the site of leakage is the CT scan and MRI, which are used for localizing the lesion. If there is any injury in the bone or the sinuses, and then in case of encephalocele or intracranial pathology, we do MRI. Treatment is conservative measures like bed rest, stool softeners, etc. Prophylactic antibiotics can be used. Acetazolamide decrease the formation of cerebrospinal fluid. Other methods like surgical repair, neurosurgical intracranial approach, extradural approach, and also transnasal approach. So to repair the site of leakage, we can use the intracranial approach, also extradural approach, and intra or transnasal approach. All these approaches can be used for the repair of any injury or damage that can occur that is causing the cerebrospinal fluid leakage through the nose. Finally, principles of repair. Principles of repair: defining sites of bone defect. We should have then preparation of the graft site. The graft, from where the graft is taken, we prepare the site, and then the defect is first found out. Then underlay grafting of fascia, placement of mucosa. Then bony defect more than 2 centimeter is repaired with cartilage. So if it's more than 2 centimeter, the defect is repaired by the cartilage. Placement of surgical and gel foam. Lumbar drain if pressure is high, too much cerebrospinal fluid, then that can cause increased pressure, and then fluid should be drained by the lumbar puncture to lower the pressure. Antibiotics can be given. Here in this picture, if you see, this is the pack, then we put the gel foam, surgical and gel foams, and then we can do, this is the placement of mucosa, bone, dura, and this is the graft. So all these are the principles of the repair. That's all about the cerebrospinal fluid rhinorrhea, how it occurs, how it is diagnosed, and how it can be managed. We talked about all this in detail in this section. Thank you for watching sqadia.com.